Hey, Dan from Jump Bag EMT here. Today we're going to go over EMS systems. So you're getting ready to start school and we're hitting those first introductory chapters. Let's do an overview. Let's nutshell it so you know the important stuff and you have a general understanding before you even begin. So like and subscribe for other trainings like this and other little tidbits and things that we're going to go over to just make life easier. So like and subscribe. So EMS systems, let's get at it. So we'll start with the origin. EMS systems began in World War I, where you had some people volunteering for ambulance services to help the sick and wounded off of the battlefield and trying to lower deaths, right? When then in World War II, we start doing some field treatment where people are actually started doing more work in the field to try to slow down those deaths and diseases. And then finally, when we get into the Korean War, we start doing field medics where people are getting trained to do this field medicine and actually treat people on the battlefield. And then we start getting into some flight ops and medevacs and things like that. And so this is where it stemmed. In 1966, we have what is called, and I'm going to read this to make sure we get it just right, is a publication called Accidental Death and Disability, the Neglected Disease of Modern Society, more commonly known as the White Paper. So lock this one in, the White Paper, 1966. This is what actually started emergency medicine on the civilian side. So 66, this brings up the idea that, hey, people are surviving better in combat than they are in the civilian world from car accidents and things. What's going on? What can we template from them so we can start doing work? And then our career field was born. So it started in the 70s when Emergency Medical Services Act of 1973 started funding sources for programs that developed to improve patient outcomes in the pre-hospital setting. Then the DOT, or the Department of Transportation, believe it or not, became the governing body in the early 1970s of who is actually going to be in charge of this, because they were really kind of focused on car accidents, right? People getting these major traumas and how can we make it better? So the DOT, the Department of Transportation, is actually the one that oversees this. And this is kind of true even today, except now it's the NHTSA that oversees it. But this is where we get all our guidance for our EMT programs, our paramedic programs, National Registry exam. All that stuff is driven by the DOT and NHTSA. So let me check the notes here. So 1971, American Academy of Orthopedic Surgeons prepared and published the first EMT textbook. And this is in 1971. And then after that, they started trying to standardize EMS education on a national level so that people all had kind of the same training. It wasn't just Joe Schmo showing up and, hey, I do stuff, right? We're actually making it more of a professional career. And so then we've continued on since then. Now the NHTSA and the DOT continues to do work organizing and setting EMS up. They've got an agenda of 2050. And so they keep doing these extended agendas where they're saying, hey, this is where we think it's going, and this is what we want to do in emergency medicine. So that's the origins. So now let's talk about the levels. We're going to start with federal, state, and then local. Federally, we got this national standard of education. This is how many hours this course needs to be. This is how many hours this course needs to be. This is the minimum standard for passing. This is what you need to do to become federal licensed. You might be taking a national registry course right now or getting ready for it. That is a federal national guideline saying, hey, these people are trained to at least this level. So that's your national, that's your federal level. Next, we go to the state. The state is what's saying, hey, you can actually work here. It's the United States of America, right? So we each as an individual state have responsibilities and rights and things they can do and manage their own. And so nationally, this is what you have to be trained to. And then state-wise, this is what we do here. This is how you get credentialed in this state. This is how you pay your dues. And we say you work for Alabama, for California, for Florida, wherever. It dials it down even a little bit more into your local level. This might seem like it a lot, but if you really think about it, you have to be trained to here. And then you go to work for a company and they say, or your state, and they say, this is what we're allowing you to do. And then you go to your local, like your department, and you're working for your supervisor. It says, these are the overarching standards. And this is where the local comes in. And under the local, that might be your city, that might be your county, depending on how your state breaks it down, that you're basically going to have medical direction. So there's going to be somebody that you're operating underneath their license. So with the medical director, they're basically saying, these are the things that I'm allowing to get done. And you are working under my license. So when you go to a doctor's office, you might show up and you see a nurse practitioner, or you might see a physician's assistant. They're not the doctor, but they're representing the doctor. And the doctor is saying what they're allowed to do. This is medical direction. This is where we get our protocols. So federally, we go off this national standard, like National Registry. This is what we're trained to, the minimum number of hours. Then for the state, this is how you work for us as an organization or for a state. These are the things that you're going to do, and these are the things you're allowed to do, and this is how you're associated with us. And then it goes to your local agency, or not agency as much, but city, county, and under a specific medical director who's in charge of that area and is allowing you to work underneath their license. So that's your federal, state, and local. Now within that, you've got different certification levels. So we're looking at EMR, EMT Basic, and Advanced EMT, and then your paramedic. And they all differ. A lot of people get confused and think it's all the same. They're like, oh, you're an EMT? Well, maybe you are, maybe you're a medic, maybe you're an EMR. All right, well, an EMR, I think of it this way, and look in your textbooks, that's what you're gonna be tested off of. Understanding, that's what we're doing right now. EMR, it's like working out of a first aid kit. You get some basic training to say, hey, this doesn't look right. You might want to put something on that, right? And so you learn how to work out of your first aid kit. When you get to EMT, you start to learn how to do an assessment and say, hey, something doesn't seem right. Let's look into it a little further. You know what? You need medical care right now. This isn't a Band-Aid thing. This is beyond what I can fix here or help. You need to see a doctor, and I can do some basic life support, helping your airway, recognizing that you're trending towards death and this isn't good. Some basic life support things. And so I might show up with a medical bag, not just a first aid kit, but a medical bag, because my skills let me see things beyond what we see as an EMR or just a first aid response. And I've got more tools I can use. So like NPAs, OPAs, managing your airways, things like that. Maybe even some medication administration for aspirin, or we'll say an EpiPen for allergic reaction. And you start learning about some of these illnesses. Next, we go to your advanced EMT. And this is between your basic EMT and your paramedic level. And what they have is a little bit more training, a little bit more scope of practice authorized underneath the medical director, saying that you're allowed to do more things. You can start an IV. So now you've got some medications on board that are not just take this pill, like you might with EMT, this oral glucose, right? With the advanced, hey, let's go ahead and give some dextrose, some D50, or let's go ahead and give this precursor cardiac medication, or let's get an IV line so we can bolus or we can bump up the fluid in their system because they're bleeding a lot or their circulation is suffering. So this is your advanced EMT. I love the advanced EMT because you don't need to carry as much of equipment as you do as medics. You don't have to have as much training as you do as medics, but you have some serious advanced life support abilities. You've got more training, more recognition, and more tools in your toolbox than you do as the EMT. And also there's less training, less equipment, and so it's going to be easier to maintain, but you're still doing a whole lot of good. So advanced EMT is awesome. And then we get to paramedic. This is your highest level of field emergency medicine. This is going to take the most amount of training, and you'll hear people say, oh, they're field doctors. We're not. I'm a medic too, and you know what? I'm not. I operate under a license of a doctor who says what I can do and what I can't do, what medications I can give, what medications I cannot, what medications I can give under what criteria and under what specific circumstances. But underneath the national and state scope, I've got a lot of stuff I can do if my medical director says it's cool. So a lot of medications. We're also looking at advanced airways. So if somebody's not breathing or they're having a hard time breathing, I can just take that tube, that intubation tube, and put it directly into their airway, bypass the whole upper airway and go directly down into where the lungs are going to separate. And now I've got positive control of the airway. Really cool things like that. Also, I can do more cardiac drugs. I can look at cardiac rhythms and see what's going on with this person who's having chest pain. And then I can give drugs specific or electrical therapy specific for what we're seeing. So it's another level of training. Your paramedic is your highest level of field medicine. So it starts with EMR, goes to EMT Basic, where you're working more out of a medical bag or maybe showing up with an ambulance. Your advanced EMT, where you're starting to start some IVs and you're getting a better understanding of how to do assessments and providing medications. And then your paramedic, which you're doing a lot more life-saving, advanced life-saving skills. You got a bigger toolbox, more tools in your toolbox. So let's go back to medical direction. So underneath your medical director, they say what you can or can't do at each individual level. They're sponsoring you. You're working underneath their license. Okay. What they provide for us is offline medical direction. Offline, which means you're not talking to them. There's not direct contact. This is where we're talking SOPs or protocols, where they say under this circumstance, you do da 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 da, right? You look at this, 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 and this. If there's this criteria, you do this, right? These are the signs and symptoms. This is the treatment you're going to do. These are your offline medical direction, the protocols that your medical director provides to you, so you get an idea of what you can do before you have to call and ask for help. Now, your online medical direction is going to be more like a phone call, where you want to do something or you're unsure about something, you call and say, help. Hey, I would like to do this. This is what I'm seeing. What do you think? Or I've already given this drug once. I want to give it again, but I need your permission to do it. This is your online medical direction. This is when you are calling 911 for you to get more guidance. I shouldn't say call 911, but you're basically calling to get some more help from your medical director or a higher level of care. So underneath your medical director also now, we're looking at things called continuous quality improvement. And this is where your documentation comes in. This is where your training comes in. They're going to be looking at the calls that people are going on and what is successful, what is not successful. They're going to look at the documentation, what drugs were working, what wasn't, what timeframes were things being done, what underlying issues were these patients having where this was successful. And then the doctors can look at these and say, hey, this is how we got to get better. We're having a ton of seizure calls. Let's do some training on seizures because for whatever reason, this is happening. Let's talk COVID, okay? There's a lot of respiratory issues going on. So let's do more training on respiratory distress, and so we can be better prepared. This is going to be your quality or continuous quality improvement, where the medical director and their staff are looking over these things and saying, what do we need to do to get better and provide better patient care? This isn't supposed to be a punitive thing. This isn't you messed up and you're getting in trouble. It's, hey, we recognize an issue or we recognize the need. Let's do something about it. All right. And this is where evidence-based medicine comes in, or EMS research. People get spooked by this because they think, oh, you're trying to catch me in my documentation saying I got to document this or that. We're showing up to save lives. Wouldn't you like to know that what you're doing has worked in the past? What if you're going off a protocol that is poorly written or inaccurate? So you're doing stuff that actually doesn't have a good patient outcome. So the patient is getting worse. You're super uncomfortable. You're trying to help, but you're applying bad tactics. This is actually where your evidence-based medicine comes in, because you're looking at what's worked in the past and how we can get better at it to make common practices, make things more standardized. So this evidence-based medicine is happening all the time. They're looking at documentation and trying to look at trends in the nation, trends in local areas to find out how we can do better things. We can do things better and help more people. So don't be afraid of it. Don't be afraid of documentation. It covers you saying I did what I was supposed to do, and also creates trends so we can do better. The point is to save lives. So let's document it accurately. Let's give them the evidence-based medicine and that continuous quality improvement so we can get better at what we're doing. Next, we're going to look at HIPAA. So HIPAA is our Health Insurance Portability and Accountability Act. And what this is for us is this is an umbrella basically saying you got to have integrity and you can't be sharing people's information. You can't just be saying, oh, this person's taking this drug or this person has this disease, or here, look at this picture of this person's leg when it was broken. There's some privacy. These people are injured and they're sick, and with their medical and their personal history, it's not meant to be shared. It's a very special thing to be called in on their worst day to help them out, to do something for them. They're trusting you with a whole lot. And HIPAA saying, don't share people's stuff. It's not yours to share. You're there to help, not share their information. And so it is a big deal. You need to know HIPAA well, because that is covering us how we need to treat people, because this is a job of privacy and integrity. We're showing up at some very vulnerable situations for people, and we need to be trustworthy. We need to be integrous. So as you go through this chapter, you're going to see a bunch of attributes of the EMT. I pretty much sum it up as you are the professional. Okay, you are the professional. You are the one that needs to have the integrity and character. They're having a bad day and they're being snotty. They're sick and they're asking for help. You are the professional that showed up to help them. So you act like the professional. You have integrity. You don't share things that don't need to be shared. You conduct yourself in a manner that's worthy of being invited into their living room. You're going to show up in uniform. You're going to be honest. You're not going to take things from them. You're going to do the best you can. You're not going to lie to them, right? We're not going to lie to patients. We need to be ethical and we need to be trained. If I'm bad at something, I need to get better. I might need to apply some, what was that term again? Write it down in the chat if you remember. It was CQI, and that's going to come from EBM or evidence-based. You guys know. Put it in the chat so we know it. So this is kind of it in a nutshell with your EMS systems. If you listen to this and you follow through these 15 minutes, you're going to fly through the chapter for chapter 1. So like and subscribe so you get more notices of this. And just remember, you're the professional. Okay, we are training for the career, not just for the test. So soak it in. Normal things happen normally. Let's make this stuff normal. Thanks for watching.